Dear students, Assalamu alaikum. Towards the end of the last lecture, we started with the study of the thromboembolic conditions and learned about various factors that can cause these conditions. In today's lecture, we will begin with the topic of thrombosis. The initial stage of thrombosis is the deposition of platelets on a vascular surface. This can occur under three circumstances. Number one, when the endothelial lining is damaged, or number two, when there is vascular stasis, or number three, when the blood stream is disrupted, causing the production of eddy currents which deflect the platelets onto the vessel wall. There are two types of thrombosis: venous thrombosis and arterial thrombosis. Let's first study the venous thrombosis. Though the veins are less commonly diseased than the arteries, thrombosis is commoner in them. There are two types of venous thrombosis. Number one, phlebothrombosis, also known as deep vein thrombosis. This is due to stasis of blood in uninflamed veins. I repeat again, in uninflamed veins. The second type is the thrombophlebitis, in which the vein wall is inflamed. So this is due to inflamed vein wall. Out of these types, deep vein thrombosis is the most important of all the complications that may follow major surgery. Other causes of deep vein thrombosis include prolonged bed rest, prolonged sitting, as in long distance flights, pregnancy, obesity, and certain medications. Coming to arterial thrombosis. Arterial thrombosis is the second major type of thrombosis formation. It is important at this point to keep in mind that, in contrast to venous thrombosis, the most important cause of thrombosis in the high velocity arterial system is disease of the arterial wall itself. Arterial thrombosis can occur in arteries or it may involve the heart. The most important causes of the arterial disease are inflammation and atherosclerosis. While thrombosis in the heart may occur in the atria, ventricles, or on the heart valves. The components of thrombi include the red blood cells, the fibrin fibers, and the platelets, but they're not as prominent in venous clots as in arterial clots. Embolism. As discussed in a previous lecture, free-flowing clots are known as emboli, and the state of having emboli in the circulation is called embolism. The emboli originating in large arteries or in the left side of the heart can flow peripherally, and they can block arteries or arterioles in the brain, kidneys, or elsewhere. While the emboli originating in the venous system or in the right side of the heart can flow into the lungs, and they can cause pulmonary arterial embolism. In deep vein thrombosis, such as femoral vein venous thrombosis, a large part of the clot disengages from its attachments and flows freely in the venous blood to the right side of the heart and into the pulmonary arteries to cause massive blockage of the pulmonary arteries, resulting into massive pulmonary embolism. If the clot is large enough to occlude both pulmonary arteries at the same time, it can cause immediate death. The treatment of clots involves the use of genetically engineered tissue plasminogen activate. Next, we study a condition known as disseminated intravascular coagulation. Occasionally, the clotting mechanism becomes activated in widespread areas of the circulation. giving rise to the condition called disseminated intravascular coagulation. The condition often results from the presence of large amounts of traumatized or dying tissue in the body that releases tissue factor into the blood. Frequently, the clots formed are small but numerous, and they plug a large share of the small peripheral blood vessels. A peculiar effect of disseminated intravascular coagulation is that the patient sometimes begins to bleed. The reason for this bleeding is that the clotting factors are excessively removed by the widespread clotting, and very few clotting factors are left to stop the bleeding. Now we study the blood coagulation tests. The platelet count. The normal platelet count ranges from 150,000 to 400,000 per cubic millimeter. The bleeding occurs when the count falls to 50,000 per cubic millimeter. Bleeding time. The normal bleeding time ranges from 1 to 6 minutes. Bleeding time is prolonged because of lack of clotting factors and the lack of platelets, which gives rise to the condition of purpura. Clotting time. The normal clotting time ranges from 6 to 10 minutes, and remember, the clotting time is normal in purpuras. However, it is prolonged in hemophilia. Prothrombin time. The normal range is 12 to 14 seconds. It's a measure of the extrinsic pathway and used to monitor the effectiveness of oral anticoagulants. Prothrombin time is prolonged in hypoprothrombemia and in liver disease. It's also prolonged in patients on heparin therapy and in conditions associated with vitamin K deficiency or the isolated deficiencies of clotting factors including fibrinogen, prothrombin, factor V, and 10. Activated partial thromboplastin time, APTT. It's also called as partial thromboplastin time, and it is a control test which is done simultaneously along with it, and it's done to monitor the heparin therapy. Activated partial thromboplastin time is a general coagulation screening test. It gives information about the intrinsic coagulation pathway involving the factors 12, 11, 9, 8, 10, and 5. Except the platelets. Thrombin time. The normal thrombin time is 10 to 12 seconds. It is prolonged in fibrinogen deficiency, dysfibrogenemia, and in conditions involving thrombin inhibitors like heparin and the fibrin degradation products. Plasma fibrinogen and FDP levels. Plasma fibrinogen is found to be low in hypofibroinogenias and in conditions associated with excessive fibrinolysis. And the FDPs in plasma and urine are also present. Assay of plasma clotting factors is also done, and factors 5, 8, 9 levels can be determined. Capillary fragility test involves the application of positive or negative pressures, and number of petechial hemorrhages is counted in skin. And these are increased in purpras. We now study a very important test known as International Normalized Ratio. The results obtained for prothrombin time may vary considerably, even in the same individual, if there are differences in activity of the tissue factor or the analytical system used to perform the test. To overcome this issue, International Normalized Ratio was devised as a way to standardize measurements of prothrombin time. For each batch of tissue factor, the manufacturer assigns an international sensitivity index, which indicates the activity of the tissue factor with a standardized sample. The international sensitivity index usually varies between 1 0.0 and 2.0. The International Normalized Ratio (INR) is the ratio of the person's prothrombin time to a normal control sample raised to the power of the International Sensitivity Index. The normal range for INR in a healthy person is 0.9 to 1.3. A high INR level, for example 4 or 5, indicates high risk of bleeding, whereas a low INR, for example 0.5, suggests a chance of having a clot. Patients undergoing warfarin therapy usually have an INR of 2.0 to 3.0. This concludes today's lecture.